Hello, my name is Megan Golden. I am co-founder and CEO of Mission Cure, and I'm here with my colleagues, Shruti Mirashankar, Olivia Zaiden, and my co-founder, Linda Martin and Crystal Kaya. I'm really excited to present the topic of high triglycerides and pancreatitis because when we started Mission Cure 7.5 years ago, we learned that to develop effective treatments, we needed to understand what was causing the pancreas to be inflamed. Pancreatitis is inflammation of the pancreas, and then work with companies and researchers to stop whatever that is. We learned that there were already companies working on developing treatments for two of the causes of pancreatitis, IgG4-related disease, and the topic of this webinar, severe high triglycerides. In the last year, the FDA has approved treatments for patients with these specific causes, and you will hear about one of them today. I want to thank Ionis and Arrowhead for supporting this webinar, and AbbVie and Amgen for supporting our patient education program. We really appreciate your support. I will hand it over to my colleague, Shruti Mirashankar, who leads our patient education program.
To everyone who's joined us today, thank you for your interest, attention, and trust. With our expert, Dr. Andreas Gelrud, we'll start with some basics of pancreatitis and triglycerides, and then dive into hypertriglyceridemia, including chylomicronemia. Dr. Gelrud will walk us through treatment options and management approaches before we close with a Q&A session. Triglycerides are one of the leading and sometimes overlooked causes of pancreatitis. Too often, patients and families don't hear how strongly triglycerides affect pancreatitis risk or what can be done to prevent disease progression. Our goal today is to provide you with a strong foundation on what triglycerides are, why their levels matter, how hypertriglyceridemia increases the risk of pancreatitis, and to share the known causes of hypertriglyceridemia. You'll learn about symptoms, testing, and diagnosis, and then discover newly approved and emerging treatments that can alter the disease trajectory. We hope this leads to faster, accurate diagnosis and effective treatment options for those living with severe hypertriglyceridemia, including familial chylomicronemia syndrome. I now welcome our expert, Dr. Andreas Gelrud, a clinical pancreatologist and advanced interventional endoscopist at Gastro Health in Florida, US. He cares for patients with acute, recurrent, and chronic pancreatitis, and also serves as the director of the Pancreatic Disease Program at Miami Cancer Institute. Beyond his clinical expertise, he's been a lead researcher in studies examining why patients develop pancreatitis with a special focus on genetics. He's committed to improving pancreatitis care, and we are thrilled to have him with us for this discussion.
Thank you so much for the nice introduction. It's really a pleasure to be here today with you, Megan, Linda. Thank you also for the invitation. It's such a pleasure to be able to talk to patients and family members because it really brings everything down to what all of us are here to do for patient care. And as you well said, to try to find a cure for these conditions and to make your life easier and better. And particularly now that we don't really have a final cure, at least we can go over a lot of things that we can do to get you better. And we'll talk about super excited medications that are commercially available now, just came out, and one that is about to be FDA approved. So there's a lot of exciting things going on for patients suffering with this condition. So let's get started. My goal today is going to be to give you a little bit of an idea of what the pancreas does, what triglycerides do, why they play such a big role in pancreatitis, and what can we do to keep them under control. So let's start with the basics. We all know what pancreatitis is because unfortunately many of you guys listening to the talk today have suffered or a loved one have suffered from this condition. But where is the pancreas located? The pancreas, it's a retroperitoneal organ. Most of the pancreas, it's actually very close to the spine and to the back and not as close to the belly as we think it is. It's near the duodenum, which is what you see here. I don't know if you can see my pointer, but you can see the duodenal sweep where the head of the pancreas is located exactly. And then you have the body and the tail. The tail is very close, frequently touching and frequently attached to the spleen. So you'll see that some patients, when they have surgery, they need to take the spleen out because it's just so tightly attached that it's impossible to keep it out when they're removing, for example, the tail of the pancreas. And I want you to look at the ampulla of Vater in the lower left. You can see that everything that is made from the liver drains at the same site where the pancreatic secretions are draining. And this is very important because sometimes when people have stones, for example, in the gallbladder, they can get stuck at the level of the ampulla of Vater, give backup pressure, and trigger pancreatitis. So I'm just saying that because you soon are going to see that's one of the main causes of pancreatitis. Alcohol, smoking are other causes, and then we see triglycerides, and we go over that in just a minute. So the pancreas has two main functions. One is what is called exocrine. Exocrine means that the enzymes are being secreted in the pancreas and they go into the duodenum, as you saw in the previous picture. And then we have the endocrine part of the pancreas, which are all the hormones that are being created and they go straight into the bloodstream. The one that we know the most is insulin because that leads to diabetes when you don't have enough or when you have insulin resistant. But endocrine means hormones that go straight into the bloodstream. Exocrine means enzymes that are going to make digestion possible. This is super, super important because imagine that you have a very sick pancreas. What may happen is that your pancreas stops making the enzymes and you have exocrine insufficiency, or the pancreas stops making insulin among the other hormones, and then the patient develops diabetes. And that's exactly things that we want to prevent. And I'll show you in a couple of slides exactly what I mean by this. You want to prevent disease progression because you may lead into exocrine and or endocrine insufficiency. By the way, when people have acute pancreatitis, amylase, lipase, proteases are being activated and drain into the blood system. This is not exactly what's happening in the body, but just for you to have an idea, imagine that thanks to the amylase, lipase, and proteases, we can eat, we can digest, we can break into tiny pieces, a piece of chicken, meat, a fish, whatever we just ate. So imagine when you have those enzymes activated, circulating in your body, the amount of damage that it can create. Here again, it's what you see, exocrine pancreas, major papilla. The pancreas was activated because the patient ate or so, and the enzymes are being secreted. They go on into the duodenum, and in the duodenum, that's where they get activated. Inside of the pancreas, they're completely inactive. But once they reach the duodenum, there's other enzymes that activate them, and then they start to function, and then they start to help digest the food so it can be absorbed in the system. So pancreatitis comes in different ways, and this is super important to understand because frequently even my colleagues don't understand the difference between them. Pancreatitis comes in these three different forms. And what I was just telling you before is that we want to prevent disease progression because we don't want the pancreatitis to go all the way into chronic pancreatitis. So what are the three different forms of pancreatitis? The first one is acute pancreatitis. That basically means that the patient had one episode of pancreatitis. How do we define pancreatitis? Abdominal pain. And by the way, I don't have to explain this to you guys. And if you're a patient or a family member, that the abdominal pain, it's not a trivial pain. The abdominal pain, it's a bomb went off inside of my belly, inside of the patient's belly. This is real pain that the patients go to the emergency department because it's constant, it's not going away, and in occasions it's only getting worse. And then we have also, in order to make the diagnosis, it's a typical pain that we just spoke, images showing that there's inflammation in the pancreas and elevation of the pancreatic enzymes, amylase and or lipase, 3 times the upper limit of normal. So 2 of the 3 makes a diagnosis of acute pancreatitis. So you have a patient with acute pancreatitis, the symptoms completely resolve, they go back to normal, and then they develop another episode of pancreatitis. 2 or more episodes of pancreatitis, it's considered to be recurrent acute. So just to backtrack this idea, if you have a stone, if you have high triglycerides, if you have conditions that can keep, that we can treat, and by treating them, you're going to prevent what is called disease progression. What do I mean by disease progression? We could have prevented the acute pancreatitis from going into recurrent acute, and then even worse, to going into chronic pancreatitis. Because there's a moment that patients have had so many episodes of acute pancreatitis that it's like a boxing match. the pancreas may give away, and then the patient may develop chronic pancreatitis. It doesn't happen all the time. It's usually one of every 3 patients may develop chronic pancreatitis, and I'll briefly show you the data. But chronic pancreatitis means that the organ is sick, they have a severe fibrosis, and these patients may develop chronic pain, they can develop diabetes, they develop exocrine insufficiency because they're not making enough insulin, they're not making enough enzymes. What happens if you don't make enough enzymes? Patients develop malnutrition, they develop vitamin deficiency, among others, vitamin D, and that's why some of these patients develop problems with their bones. But the message that I really want you to remember is that it's really, really important to make the diagnosis early in the course of the pancreatitis so we can prevent disease progression. We can prevent the patient developing chronic pancreatitis. So here you have 3 different CT scans. In the left, a normal pancreas, and you can see the arrows showing an organ that even if you don't know anything about CT scan, it looks very well demarcated, well delineated. Then to the image in the middle, it's a patient with acute pancreatitis, and the arrows are showing you a lot of water, a lot of inflammation, a lot of edema around the tail, particularly in this picture, around the tail of the pancreas. And if you look to the right, that's a patient that you see those white dots in the duct and in the parenchyma. That's called chronic pancreatitis. So here you can see what a normal pancreas looks, a pancreas with acute pancreatitis, and a pancreas that is very sick, a pancreas that has calcifications, dilated pancreatic duct, and that's what we call chronic pancreatitis. This is what we do in patients with chronic pancreatitis because they have pain, they have diabetes, they have exocrine insufficiency. So what you see there in the upper left is a stone blocking the pancreatic duct that frequently it leads to pain. In the middle, you have an ERCP image of a very dilated pancreatic duct. And that's tricky because that may be a stricture, that may be a tumor, that can be many, many different things. In the upper right, hopefully a lot of the people watching this talk do not have this, but this is clear-cut chronic pancreatitis with exocrine pancreatic insufficiency. Why? You see actually the fat droplets floating in the toilet with pale-looking stools. Why do you have fat droplets in the stool? We just spoke. If you have chronic pancreatitis, a subset of these patients may develop exocrine pancreatic insufficiency. And when you have that, if you don't take enzymes, whatever you put in your mouth, you're going to be malabsorbing. And if you ate a significant amount of fat, or in some patients, a little bit of fat, you may see these droplets in the stool because your body doesn't have enzymes. You are not absorbing what you just ate, and that's going to go down, excuse me, the pictures and the word, but it's going to go down to the toilet. And again, if you start to take enzymes, you're going to solve this issue. And then in the picture in the middle, you see an ERCP with 2 stents keeping the duct open. And in the lower right, you can see a basket with 2 white stones that are being removed from the pancreatic duct. So what's a natural history of acute pancreatitis after the patient have one episode? There's multiple studies. I'm just going to show you the 2 that have the greatest number. In this one, 7,000, almost 500 patients show that approximately 1/3 of patients may progress into recurrent acute and then chronic pancreatitis. And to make a long story short, one of the take-home messages of this study is that if you are drinking in excess or if you're an alcoholic, you have to stop. If you are smoking, you have to stop because smoking and alcohol, they damage the pancreas. So these are one of the few things that you can do to really prevent ongoing damage. And the third take-home message is that if you have stones that you should in the gallbladder, that you should remove the gallbladder soon to prevent other episodes. These studies did not talk about triglycerides, but I'm going to add the following comment. If you have high triglycerides and you keep them low, it would also decrease the chances of a disease progression and having more pancreatitis. Then we have another study that came also in the year 2015. This one has 8,492 patients, and the results were very, very, very similar. After the first episode, 22% progressed to acute, 10% developed chronic pancreatitis, but the message continues to be the same. Whatever you can control to prevent disease progression we should do in order to assure that our patients won't continue to develop pancreatitis. And in these studies, again, we're talking about 2015, when we didn't know what we know now. We didn't have all the genetic studies that we have now. So believe me, everything has come a long, long, long way. So here, again, they're talking about stop smoking, stop drinking, and remove the gallbladder in a timely fashion. And if you're a man, you have higher incidence of disease progression. And again, this study did not talk about high triglycerides, but I'm going to add that if you had hypertriglyceridemia, induced pancreatitis, you keep the triglycerides under a low level, and this pancreatitis should not happen again. So again, this is what we do to prevent disease progression. So what's a basic workup that we should be doing in the emergency department? Now that most of the ERs throughout the United States have electronic medical records, in most of academic institutions like ours, this is going to appear when you're writing down the diagnosis of acute pancreatitis. You'll have a prompt that tells you, remember to check triglycerides, calcium, ruled out celiac disease, that it can also lead to pancreatitis in some cases, thyroid hormones. Megan spoke about autoimmune pancreatitis. In some cases, we check IgG4. And genetic testing is something that we do in patients with recurrent acute pancreatitis to make sure that whatever condition, after you have ruled out what you see here, that we can rule out other genetic predispositions and other conditions that lead to pancreatitis. So what are triglycerides? Triglycerides play a major, major role in the function of the body. And that this is just a different type of fat that circulates in our body. This comes from the diet. As soon as it's absorbed, it's created into triglyceride, and the liver also makes triglycerides. They are transported. The functions are many, many functions. This is just some of them: to provide fuel, energy to the muscles, protect and insulate different organs, and also helps with the absorption of different vitamins that are fat soluble, like vitamin A, D, E, K. Again, you don't want to know these details, but the message that I really want you to remember is that fats, they do play a role in the entire body when it comes to energy, isolation of the organs, insulation, of the organs, and some vitamins. Then we have cholesterol, again, have similar functions, and it also helps with the structures of the cells and different membranes. So this is just to keep it in mind. How triglycerides travel, they travel in different forms, and I don't want to get you bored with the micro details, but we have triglycerides that are being transported in what is called lipoproteins. And these are just a combination of different types of fat with proteins, and that's how they go from the liver to our entire body, and that's how they go from the intestines, again, to the entire body. And I don't want to get too hardcore lipid here because I don't want to lose your attention, but it's fascinating to see how the body makes them, transport them, and deliver them to the spots where they need to be. Here you can see the two different forms of triglycerides. As I just told you, when we eat, a lot of the triglycerides are going to be made. That's why it's so important, if you suffer from high triglycerides of any type, any form, any condition, to make sure that you have a strict low-fat diet. Super important. And then we have the endogenous form of making triglycerides, which are the triglycerides that come from the liver. The liver can metabolize different type of fats and create triglycerides. So in a healthy individual, what I want you to remember, what we spoke about, the small bowel, which is what you see in the middle of the cartoon in the left, and then in the right where it says liver, fat, it's being made, it's being transported in the form of chylomicrons. And then we have this super important enzyme that is called lipoprotein lipase that you see exactly. And that lipoprotein lipase plays a major, major role in the breakdown of these chylomicrons, triglycerides, so they can be used in different parts of the body. So pay attention to this lipoprotein lipase, because when we briefly talk now about a familial chylomicronemia syndrome, the problem that patients with this condition have is that this LPL or lipoprotein lipase, it's either lacking or it's significantly reduced. So it's something to keep in mind. This is super important. So here what we're showing is the different levels of triglycerides that are going to put the patient at different risk of developing pancreatitis. In general, we try to keep the triglyceride levels below 500 to prevent pancreatitis. But I can tell you that we have patients with familial chylomicronemia syndrome, for example, and I see them in my office with triglycerides of 2,000, 3,000, 4,000, and they look like you and I. But the problem is that at any moment they can develop a pancreatitis. The bad news that I have for anybody that suffers from high triglycerides is that there's newer data also that shows that even lower levels, when the pancreas it's predisposed to pancreatitis, may trigger pancreatitis. So even if a patient has a 300, 400 milligrams per deciliter, that may be a risk factor for pancreatitis, and they can develop pancreatitis. From this slide, what I really want you to remember is that the higher the triglyceride level is, the higher the risk of pancreatitis it's going to be. So here you have why triglycerides cause a acute pancreatitis. And again, most of these are just theories, but we know that when the triglyceride levels are very high, the blood, it's going to get very dense. And if we have anybody here listening that has a FCS, for example, you'll know that sometimes patients develop what is called the brain fogs. And that's basically poor perfusion of blood inside of the brain that leads to these symptoms. And once the triglyceride levels go down, the brain tends to clear. So what's happening in the pancreas? You have very dense blood that may lead to a little bit of hypoperfusion that may lead to early activation of these enzymes that also leads to the creation of free fatty acids that actually may lead to acute pancreatitis. And again, these are theories, but when you look at them, it makes a lot of sense. So the take-home message, we want to keep triglycerides low, and something that I haven't mentioned before, you want to keep your body well hydrated. Why well hydrated? Because the pancreas is an organ that likes to be surrounded by water. So the more perfused the pancreas is, the better it's going to function. And just to keep it in simple words, the happier the pancreas is going to be. So make sure that if you suffer from pancreatitis, you are well hydrated 24/7. This is one of the few things that you can do to control this condition. So this is a slide that it's extremely important, because if you have high triglycerides, that doesn't mean that you have a genetic mutation. That doesn't mean that you have a familial chylomicronemia syndrome. Make sure that you are excluding alcohol, because alcohol, when you drink alcohol, the way that it's absorbed in the body, it goes straight into triglycerides and other forms of sugar. So alcohol needs to be taken out of the equation. Poorly controlled diabetes, it's another one that must be taken out of the equation, because diabetes means high sugar means high triglycerides. And sometimes we see these patients coming in with pancreatitis. They didn't even know that they had diabetes, but the initial presentation of the diabetes may be pancreatitis. So the point that I'm trying to make, if you have diabetes, make sure it's well under control, because poorly controlled diabetes can give you high triglycerides that may trigger pancreatitis. Medications. Oh yeah, nowadays there's so many medications out in the market, and when you start to look at the side effects, some have a higher risk and medium risk or lower risk of pancreatitis. So this is something always to keep in mind, and the list is just long. There are other medical conditions like lupus, for example, pregnancy. In the third trimester, it's normal for the triglycerides to go a little bit up. So that a little bit up for that woman may be enough to trigger pancreatitis. And believe me, we see them in the ER, and we see them in the hospital. So these are things just to keep in mind, things to consider. And there's other medical conditions that lead to pancreatitis. So just remember that high triglycerides may be many conditions that at the end, they just look as a number in your lab results that it's high triglycerides. But what led to the high triglycerides can be a lot of the things that you see in this slide. That's why this slide is so important. And of course, the primary etiology, it's genetics. Genetics means that there's something in your body that makes your body produce too much triglycerides. But what we see the most is that your body, it's not able to clean the triglycerides out of your body. And the other mechanism, it's familial chylomicronemia syndrome, that your body doesn't make the LPL and other enzymes that clean the triglycerides and the chylomicrons out of your body. And this is just to keep it simple so you can understand the strong message that I'm trying to give. So why is hypertriglyceridemia so important? What I want you to know from this slide, and I don't want to go into too much details, is that when you look at patients that came in with acute pancreatitis that had normal triglycerides versus patients that were admitted to the hospital with high triglycerides, what happened to the patients that had high triglycerides? And this is all comers. Any patient that had high triglycerides versus normal triglycerides, both of them came in with acute pancreatitis. What happened to the patient with high triglycerides? They stay in the ICU much longer. They develop pancreatic necrosis in a higher percentage. They have persistent organ failure, and they stay in the hospital, as you can see in the right, much longer compared to the ones that had normal triglycerides. So if patients had hypertriglyceridemia, pancreatitis, they would stay in the hospital for approximately 17 days versus the one that had a normal triglyceride level that usually stayed for 7 days. And when you look at the numbers, the mortality was very similar, but you can see high triglycerides, 8 died, and a normal triglyceride, it was only 3. So even though there's not a statistical significant difference when it comes to mortality, you can see that more patients with high triglyceride died when compared with normal triglyceride. And this is all comers with acute pancreatitis. So severe hypertriglyceridemia can come in 3 different forms. So you have patients that have a FCS, Familial Chylomicronemia syndrome. And this patient, as we'll talk in a minute, it's a very rare disease and it's a genetic disorder. These patients usually have the triglyceride over 880. In my experience, it's over 1,000, and it's quite impressive. Then you have multifactorial chylomicronemia syndrome. These are patients that do not have any established genetic mutations, but they do have genetic risk factors, but the genetics are different from the FCS patients. It can be related to their lifestyles. It can be related to different medical conditions like we were talking about before, but these are patients that also have very high triglyceride levels. And then you have the secondary, which is what we were talking before about taking a medication that they didn't know could raise them, having other conditions, like diabetes, poorly controlled, Addison's disease, lupus, etc., that may raise also your triglyceride levels. And the picture that you have here to the right, it's a picture actually that I took with my own camera of one of my patients with high triglyceride. So I can tell you that the triglyceride column that you see here in the top, that it's a milky looking fluid, should not be visible in any of us. So if you have normal triglyceride levels and you do what you see here, which is to separate the different layers, you would never see, you may see a tiny white line, and that's about it. So I think this picture speaks for itself. By the way, frequently when the patients have such a high triglyceride level, the lab is calling us to tell us, listen, we have what is called a blood sample. As soon as they get the blood in their lab, they can see that a white column is starting to accumulate, and they call us to let us know. And that frequently means that the triglycerides are very high. So what's familial chylomicronemia syndrome? To the right here, you can see how it's passed from parents to kids. This is an autosomal recessive condition, which basically means that mom has a mutation, dad has a mutation, they have a baby, and one of the kids will have both mom and dad, and that's why they develop the disease. If you only have one mutation, you're unaffected. You need to have both alleles to be affected in order to have familial chylomicronemia syndrome. It's a very rare disorder, but many of us think that very likely it's more prevalent than what we think, but it's under-recognized. Triglycerides are usually 10 to 100 times greater than normal, and it affects 1 or 8 people per million of the population. The age of onset, 25%, it's affected when there are children. The majority develop symptoms by age 10, but there's also late onset in adulthood that you can see. Sometimes in pregnancy, in the 3rd trimester, the diagnosis will be made because they come in with pancreatitis. And the overall mortality can be up to 6%. 30% in subgroups of severe acute pancreatitis patients. So individuals with familial chylomicronemia syndrome have what we were talking before. So this is the same slide that we showed you before, but these patients have lack of LPL or very low levels, as you can see here. So you're going to have chylomicrons that are super rich with triglycerides circulating all over your body, and they're not being cleared because you don't have the enzyme in charge of breaking the chylomicrons and then the triglycerides. So that's going to lead to very high levels, despite having a diet that may be very restricted in triglycerides. In fact, the levels can be very, very high. And it's not only the LPS, there's other genetic mutations. And I'm not going to go into the details, but you have it here in the left part of the text. But what I want you to remember is that it's a genetic condition that leads to very, very high levels of triglycerides and, unfortunately, to pancreatitis. How do we make the diagnosis? The diagnosis in occasions can be very difficult to make, but us as physicians should keep what you're about to see in mind, because there's a lot of red flags that we tend to see that frequently are missed in order to make this diagnosis. So number one, it's severe refractory hypertriglyceridemia, which means that the triglycerides are very, very high in the 1,000 range, over 180. It's what most of the studies say. And what do we mean by refractory? Refractory means that we're giving treatment and the triglycerides are not going down. So us as physicians, we would think, oh, maybe the patient is not taking the medication, maybe they're not complying, and we blame it on the patient instead of thinking that they may have this very rare condition. So I do ask patients, and particularly you guys, to create consciousness that bring up this type of diseases with your primaries, with your doctors, because frequently doctors don't even know that these conditions exist. So when patients Google things, or they go into ChatGPT or any type of AI, nowadays they're coming to us telling us, listen, I think I could have this diagnosis. And so pay attention, because, refractory to treatment, in my head, basically, it's a major red flag that this patient may have FCS. The clinical history is super important. They would have a history of acute pancreatitis. They can have a history of recurrent abdominal pain, et cetera, and we'll show a slide to come on other presentations. Absence of secondary causes, it's super important. We as physicians have to make sure the patient is not drinking too much alcohol, that they don't have poorly controlled diabetes, that they're not taking medications that may lead to high triglycerides, etc. So how do we make the diagnosis? Again, the triglycerides are high. They don't respond to standard treatment. We have the chylomicrons, which you can see the pictures here on how creamy these layers look of high triglycerides. And again, if they have hypertriglycerides since childhood, we have ruled out other etiologies. Fasting levels are very high, recurrent abdominal pain, fatigue, malaise, cognitive impairments, etc., etc. And of course, if they have a history of FCS, it's something to, of course, to keep in mind. So how do we confirm the diagnosis? There's a clinical scoring tools that are available, and you can see that actually they're published. You can find them in the internet. There is the European criteria, and we have actually the National Lipid Society that just published a couple of months ago here from the United States as well, clinical scoring tools. Why is this so important? Doing genetic testing, it's not always easy. It's not always available. It can be a little bit more expensive. So it's something, of course, that would be the gold standard, but it's not mandatory. Of course, send the patient to a lipid expert. A lipid expert may be an internist, an endocrinologist, a cardiologist that can help you with this. And if the patient is diagnosed with FCS, it's important also to test the siblings and make sure that they don't have very, very high triglycerides. What are the signs and symptoms? They can vary quite a bit. They can have recurrent acute pancreatitis, as we just said. They can have actually low platelets. The patients can develop hemolysis. They have hyperviscosity, as we said before. They can have neurological symptoms, like we were saying, memory loss, fatigue, neuropathy. They can have what is called eruptic xanthomas, which is what you see in the right, in the middle, and in the lower panel. These are literally fat accumulations, these lesions that you see in the skin. You can also see fat deposits in the eyes when you get an eye examination. So this is all very, very important to do a good physical exam. And you can imagine the emotional burden that this condition has over the patient and the family. These are the type of conditions that affect the entire family. It leads to anxiety, it can lead to depression, a lot of social constraints. Why? You can go to a party, you can go to a dinner. Actually, you can go, but you have to be incredibly careful with what you eat, what you drink, so you don't end up in the hospital with an episode of pancreatitis. What are the challenges for patients with familial chylomicronemia syndrome and HOPE? It's a difficult diagnosis to make. It is very difficult and very challenging to keep a diet that it's low in fat, that it's 20 grams or less per day. That would be basically 3 small tablespoons of olive oil. So you can imagine how easy it's to eat or drink more than that and to end up triggering pancreatitis. Again, the medications just don't work. They're not effective. And the treatments, it's super important. And we'll talk about that in just a second. There's actually only one FDA-approved medication, and there's a second medication that is going to be FDA-approved, hopefully, next month. So these two are the most important studies of the two medications that one is commercially available, which is the one in the top, and the one in the bottom, it's about to be commercially available, hopefully next month. But you have this New England Journal of Medicine studies. This is one of the most prestigious journals that we have in the medical world. And this is for you, the patients, to understand this. And for these studies to be published, it means that the studies were conducted in an ethical way, that they have a good amount of patients, and that basically that you can 100%, well, nothing is 100%, but that you can trust the results. And basically, both of these studies, what they showed is that patients with very high triglycerides from familial chylomicronemia syndrome responded very, very well to these medications, and that it prevented and it significantly decreased the number of pancreatitis episodes in this patient population. So the best care for this patient is multidisciplinary approach. You need a dietitian, you need a pancreatologist, lipid experts, endocrinologists. Sometimes surgery is needed, a pain specialist if the patient already has chronic pancreatitis with chronic pain, radiology, social services, psychiatrists, mental health professionals. And you know what? We put it here in the lower in the list. If you ask me, after seeing so many patients with pancreatitis, this may be the one that should be the first in the list, because providing this help for the patient and the family, it's super important. Restricted diet, sugar, fat, and no alcohol, etc., and complementing actually multivitamins, it's super important. So to summarize, before we go into the questions and answers, a severe hypertriglyceridemia, and this is all comers, think early, suspect about severe hypertriglyceridemia in patients coming with pancreatitis, abdominal pain with very high levels of triglycerides. Remember what I showed you at the beginning, high triglycerides and pancreatitis, they do worse when they're in the hospital. They stay much longer in the hospital. And if we can make the diagnosis early, hopefully we can prevent more episodes of pancreatitis and we can prevent more admissions, not to mention we can prevent disease progression. Find the cause, as we just said, ruled out secondary etiologies, medications, other conditions, do genetic testing if possible. If not, we can use the other criteria, the American Lipid Society or the European criteria. That's going to help. We must prevent disease progression. And I know I'm getting you bored by repeating this so much, but this is super important. That's why actually we give treatment, not only to prevent pancreatitis, but to make sure that the pancreas doesn't suffer and that the pancreas continues to do everything that it must do for the body to work the right way. Therapies, hypertriglyceridemias, yes, lifestyle modification changes and different medications, familial chylomicronemia syndrome. Patients with this condition are now lucky that there's medications that are commercially available that are going to help bring down these triglyceride levels and prevent pancreatitis. Just keep in mind, please, that these new medications for familial chylomicronemia syndrome, all of the studies were done with patients keeping a very strict diet. So keep that in mind, and we can talk about that after. what's in the pipeline. There's other medications coming in. Hopefully, they're going to be FDA approved very, very, very soon. And the best outcome for these patients come with a multidisciplinary approach of care, so everybody can pinch in and give a little bit of the thoughts to make sure that these patients do well, short and long term. Actually, not only the patient, but also the family members. And thank you so much again for the invitation. And thank you so much for listening to this webinar.
Thank you, Dr. Gelrud, for helping us better understand hypertriglyceridemia and familial chylomicronemia syndrome. Your insights on its connection to pancreatitis and opportunities for prevention were very helpful. I'm sure patients and caregivers dealing with high triglycerides will benefit from your guidance. It was also a pleasure working with you. And to our audience, we have listed resources here, and they'll also be made available along with the webinar recording on our website soon. In the coming months, we plan to share patient journeys, allowing you to listen to the experiences of your peers. If you haven't already, please visit our website to subscribe to our newsletter and follow us on social media handles to receive these updates.
Dr. Gelrud, thank you so much. That was fantastic. I learned a lot. I have a couple questions for you. I will start, though, with a couple that have been submitted thus far. One, I think, might have come up on one of your slides. Does acute pancreatitis cause due to hypercalcemia and result in increase in triglyceride levels?
That's a very good question. So usually what we see in the real world, it's patients coming with very high calcium levels and frequently with pancreatitis, by the way, and occasionally they may have an underlying cancer that have hormones that stimulate calcium production. So that's why when we hear the word acute pancreatitis in the ER, a lot of the older people and physicians, or it's hard for me to find the exact word without being condescending to my ER doctors. But if you're only thinking about smoking and drinking, you have a problem. And unfortunately, that's what we tend to see the most. What I mean by that is that nowadays, in the year 2025, you have a patient with acute pancreatitis. Of course, you ask about drinking. Of course, you ask about smoking. But you must keep in mind triglyceride, calcium, celiac, TSH, medications, and others. So that's a good question on the high triglycerides. And that's, as you just said, I showed that in one of the previous slides. And I know I gave a lot of information, but I'm happy it's going to be in the internet so people can go back with the slides. But hypercalcemia, absolutely yes, it can trigger pancreatitis, and we see it in the real world.
Do you have any advice for patients who are going into the emergency room and are simply just being told, oh, you drank too much, go home and stop drinking? How do they advocate for themselves to get all of those tests, or at least a deeper inquiry into the causes?
Megan, that's an excellent question. And nowadays, there's a new test that we can check in the blood for alcohol within the past 3 months. So what I would strongly encourage the patients is to tell the doctors, listen, check an alcohol level. I heard somewhere in the internet that there's a new test that you can check for the past 3 months. Please check it. So you can see that I'm not an alcoholic. I wish I could drink alcohol, but I always encourage my patients to tell their doctors to check for alcohol. And the other thing that I do with my patients is I give them a copy of one of my notes stating that the patient has a genetic condition or that the patient has something that led to the pancreatitis and that it's not alcoholism. But I think that telling the patients to check for alcohol, it's a very good idea. And by the way, when I have patients that I'm meeting them for the first time, I will tell them that I always encourage the ER doctors to check for alcohol levels so they can see 2, 3, 4, 5, 7 admissions with acute pancreatitis. 0 of them had anything to do with alcohol.
Thank you. Another question submitted. What is the timing of acute pancreatitis happening after eating fatty meal, which can trigger acute pancreatitis? If a patient is not eating and checking blood after 24 hours of the first symptoms, will it be visible in the results?
That's a good question. In the majority of the patients, it's soon after they ate. Why? They eat, they stimulate pancreatic secretions, and then the triglyceride levels go very high, and boom, you develop a pancreatitis. I can tell you that with patients with very high triglyceride levels, It can happen at any time, and you can make a small mistake with what you ate, with what you drank, and then you end up with pancreatitis. So that's a difficult question to ask in the sense that the majority, it's soon after eating, but patients with very high triglycerides, it can happen at any time.
I guess the other part of the question is, if you do have acute pancreatitis triggered by high triglycerides and you like a day later, you get your blood tested, will the triglycerides still be high, or is that a temporary thing?
A very good question. And by the way, I should have mentioned also in the previous answer that remember we show a graph that the higher the triglyceride levels, the higher the risk of pancreatitis. So you can imagine that after you eat, that's when you're going to reach the higher level. So usually it happens after you eat because that's when the higher level it's going to be. And going to the second question, usually the triglycerides go down when you're fasting because there's going to be some clearance. So if you look, we always check triglycerides when the patients have had nothing to eat or drink for at least 6 to 8 hours. We tell them to be NPO since midnight, and then they come to the office at 8 a.m. and you see them relatively low. So my concern is that we're checking blood when you don't have anything that you just ate, and the likelihood that the triglycerides are going to be relatively low, it's high because the patient has been fasting. So if you ask me, and that's what I tell my patients with hypertriglyceridemia and pancreatitis, I tell them, I don't care if you're fasting, I want you to eat. Because if the triglycerides are going to be in the 1,000 range, I want to see them. I don't want to see them when they're going to be relatively low because you have been fasting for 8, 9, or 10 hours. So if you look at the guidelines, it's NPO. But if there's any lipid specialist listening at what I'm telling you, they may think that I'm crazy. But for me, that I'm a pancreatologist, for me, that I want to prevent pancreatitis, I tell the patients to eat and then to get the triglyceride levels checked.
Very helpful. Can you tell everybody what NPO means?
Oh, sorry, nothing by mouth. Actually, in reality, it means nothing per os. And os basically means mouth.
So at Mission Cure, we've heard a number of patients say that pancreatitis flares correlate with their menstrual cycle. And nobody seems to know why. But now I'm hearing you saying pregnancy can cause high triglycerides, certain hormonal medications can cause them. I actually had high triglycerides when I was pregnant. So could it possibly be that flares correlated with menstrual cycle have something to do with triglycerides?
I don't think it has to do with triglycerides. It has to do with hormones. And I don't remember the explanation, but I know there's a hormonal explanation of, I think it's estrogen or progesterone receptors at the level of the acinar cells. I don't want to give you the wrong answer, but I know that some patients tell us that, that it's related to the menstrual cycle. Be very careful also because there's a condition called endometriosis. It's a rare condition also, but we see it quite a bit. And when females are menstruated, the endometrium, that it's ectopic, it may be near the pancreas, around the exit of the pancreas, around the ducts, etc. So it may trigger pancreatitis also. I don't remember the exact mechanism, but that has been described, and that's something that we know. Excuse me that I don't remember the answer exactly, but what you're saying I have heard many times in the past also.
Thank you. And I'm not sure if this is too specific, but this is somebody who has had chronic pancreatitis for 5 years with EPI and type 3C diabetes and is 99% pain-free, but with daily nausea and fatigue, previously normal triglycerides, but now her triglycerides are elevated. Is there a pancreatitis-related reason for that?
Oh, yeah, I need more details. Megan, to give you the right answer, I need more details. But one of the things that happen also once the patients are diagnosed with exocrine pancreatic insufficiency and they start treatment, guess what happened? Remember the picture that I showed that you see the fat droplets in the stool? Now all of that is being absorbed. So that's why I'm telling you I need more details because maybe the triglycerides started to go up once the patient started pancreatic enzyme replacement therapy, which basically tells you that the patient is taking the enzymes correctly and that the medication is working. So I need more details, but Hopefully that's the right answer, that the patient is taking the medication and it's working, and that's why the triglyceride is going a little bit higher, because finally the patient is absorbing what he or she is drinking, eating, etc.
I do have a question that I want to ask. It came in the chat box, so I'm going to highlight it. My wife has been diagnosed with hereditary pancreatitis and is having recurrent acute attacks every 15 days, sometimes every month. She underwent 3 surgeries for removal of calculous stones in pancreatic duct. We went for genetic tests and resulted in SFINC1 and CFTR. And she has high triglycerides, which are over 300. Can we reduce the triglycerides by taking any medication or some of the medications that we've discussed today? So if you want to shed any light in terms of when people show up with multiple potential causes, including triglycerides that could potentially lead to pancreatitis, what would be the treatment approach?
Absolutely. I mean, triglycerides of 300, I'm sure they should be relatively easy to treat. The ones that are challenging are the ones that are in the 1,000 range, but 300 should be relatively easier to treat. And again, I don't want to put that factor down. But what I do want to mention is that if she has multiple genetic conditions that are disease-causing gene mutations, and she's having debilitating pain, or she's having multiple hospital admissions, there's a very radical option that it's called total pancreatectomy with auto islet cell transplantation to prevent diabetes, which basically means that we remove the whole pancreas in order to take the source of pain out. We separate the cells that make insulin and we put them back in the patient's body to prevent what is called brittle diabetes, difficult to control diabetes. So some patients that have very debilitating pancreatitis from underlying genetic mutations, we do this surgery that you can see it as an extreme, but when you look at the published data with multiple patients having this for, again, debilitating disease, the quality of life significantly improves. So I would try to bring the triglycerides down, but when it comes to genetic mutations, debilitating disease, that's when I start to think about just taking the whole gland out and, if possible, doing an auto islet cell transplantation.
Well, hopefully with the new medications and more education like this, we will get to the point where that will never be necessary. In the meantime, thank you so much. We need to wrap up, but really appreciate your sharing with us today and with our community. And I want to turn it over to Olivia to wrap up.
Thank you to everyone who joined us today. On behalf of the Mission Cure team, we extend our sincere gratitude to Dr. Gelrud for his time, effort, and support in making this webinar possible. It was such a pleasure to hear from you. We post resources for our patient community as part of our patient education program. So please subscribe to our newsletter and follow us on social media to learn more. You can also explore past webinar recordings anytime on our YouTube channel. If you have any questions or comments, feel free to reach out. We'd love to hear from you. Thanks again, and I hope you enjoy the rest of your day.
Bye, everybody.
Before you go, don't forget to hit the like button. And if you haven't yet, click subscribe so you don't miss our next expert-led session.